Assalamu alaikum and good morning, everyone. I'm going to talk about a very important topic of periodontology, that is Papillon-Lefever syndrome. So before starting with Papillon-Lefever syndrome, I would like to tell you that according to new classification that is given in 2017, the classification of periodontal and peri-implant diseases and conditions. So based upon such classification, Papillon-Lefever syndrome is falling in periodontitis as manifestation of systemic disease. I would like to begin with a little of this article that shows that basically our periodontal disease and conditions are divided into different groups. First, they said like some of the conditions are coming under health, some of the conditions are going under periodontitis, and some are conditions that are usually occurring due to, not purely due to periodontitis, but there are some conditions that affect the periodontium. So that's why this condition, which we are going to talk about, that is Papillon-Lefever syndrome, due to which patient is suffering from periodontal attachment loss, that falls under this category of 2017 classification. Okay, so this category is systemic disease or a condition affecting periodontium. That is given by Jaspin and his co-workers, and they described that there are several systemic conditions that affect the periodontium in different way. So what are those systemic conditions that are affecting the periodontium? They are broadly categorized, and this broad category is saying that systemic, out of these, all the systemic conditions are acting differently. Some of them impact on periodontal tissue, means they directly act on the periodontal tissue and they cause inflammation of the periodontal tissue, due to which patient is suffering from periodontal loss. So in this category, means this category of systemic disorder is further categorized into small categories. One of the category is purely the systemic condition is impacting the periodontal tissue, leading to loss as well as periodontal inflammation. So under this umbrella, there are several conditions which are actually occurring leading to the periodontal loss are, first of all, genetic mutations or any disorder that's leading to genetic alteration. So that genetic alteration is doing what? That decreases the neutrophil function and macrophage function, means it decreases the phagocytic activity of the neutrophil and it decreases the chemotaxis of phagocytic activity of macrophages is reduced and the neutrophil chemotaxis is reduced in order to combat with disease. So there are so many conditions that are occurring or that are falling into this genetic disorder. We are just picking this one because we are going to talk about the Papillon-Lefever syndrome. So systemic disorders causing periodontal loss with inflammation, amongst several, we are talking about genetic disorder, and from genetic disorder, we are talking about Papillon-Lefever syndrome. I would tell you a little, there are other genetic disorders that actually act on the mucosa and gingiva. There are a few other genetic disorders that are affecting connective tissue. Some genetic disorder that lead to metabolic and endocrine disorder, some genetic disorder leading to immune deficiency and inflammatory disease. But we are only talking about the genetic disorder that is causing problem with immune function. And there are several problems or several genetic disorder which are occurring due to immunological disorder. Out of those, we are going to talk about Papillon-Lefever syndrome. Okay, so Papillon-Lefever syndrome, we'll be talking in detail, but I'll give you a little about the same classification of Jaspin. They say there are few systemic disorders that actually influence pathogenesis of periodontal disease. Means these conditions were directly acting on periodontal tissue They were directly causing periodontal trauma, that directly causing periodontal loss. But the conditions like this, they are not directly causing the loss, but they act as a risk factor. Means they are somehow present in the background in causing the disease, in causing the periodontal disease. That includes diabetes, obesity, osteoporosis, medication, etc., etc. And there are some systemic conditions that result in periodontal loss independent of periodontitis. Means these are the conditions that do not require any periodontitis in patient's mouth. They themselves are self-sufficient in causing periodontal loss. So we again repeat a little. This was causing loss with inflammation, matlab influenced by periodontal inflammation. Second thing, but the second category was causing periodontal loss, but it was not directly causing it. It was somehow acting as a background. And third is causing periodontal tissue attachment loss, but that is independent of periodontitis. Means patients do not need to have a periodontitis as a result of these conditions. So they somehow cause the destruction or they somehow cause the loosening of the teeth or periodontal tissue loss due to other factors via other mechanism. So that was a nutshell of that classification of Jasper and his co-workers. So out of that, we picked Papillon-Lefever syndrome. So what is it? It is actually the condition, though rare, but it occurs at an autosomal recessive disorder. Autosomal recessive disorder, that is genetic disorder, that result as keratosis of the palm. I'll be showing you the pictures. The keratosis of palm and plantar keratosis, rapidly progressive periodontitis affecting both the dentition, the primary as well as permanent dentition, and due to which there is premature loss of both the set of dentition, the permanent as well as deciduous. So why it is occurring? It is actually, as we said, it is a genetic disorder. This means that there must be some problem with the gene. There must be some mutation in the gene. So the gene that is mutated, that is CTSC. CTSC gene is the one which is actually mutated in this condition. And where is this gene present? That is present on chromosome number 11 at its Q arm. So mutation of this CTSC gene that is present on chromosome number 11q, and that leads to alteration of cathepsin, that is a protein. When this cathepsin protein is altered, so it actually acts on the neutrophil activity. Due to this deficiency of cathepsin gene, the neutrophil is defective, because it is not supplied with sufficient of this protein in order to perform its function. So in this pictorial, I'll show you that what happened in Papillon-Lefever syndrome. There are two arms of chromosome. This is Q arm and this is P arm. There is a mutation in the Q arm of chromosome number 11. When this arm is mutated, what happens? The gene which is present over here is definitely mutated. There's a mutation present of the gene. Which gene was mutated? We said there is a gene called CTSC gene. This CTSC gene is actually the one that is essential to make this protein. This protein is called as cathepsin C gene, the cathepsin C. So alteration of this gene led to abnormal or defective production of cathepsin C. This cathepsin C was actually a food, a good food for this neutrophil. When this neutrophil is not sufficient, getting sufficient food, assume this is acting as a poliovirus for the neutrophil, this deficiency. So what happens? The neutrophil become unable to move. It has lost its ability to move from one place to another. You know, when there is infection in the body, we need neutrophil to go to come into the field that is called as chemotaxis. So the chemotaxis of the neutrophil, or walking ability, or you can say crawling ability or running ability of the neutrophil is lost because of this defect in the neutrophil function. So in a nutshell, we said that Papillon-Lefever syndrome is a rare recessive genetic disorder that occurs due to mutation of gene that is present on chromosome number 11. This gene that is present on the chromosome number 11 is called as CTSC gene. And what is the function of this CTSC gene? It was essential to form this cathepsin, because it codes for this cathepsin protein. And this cathepsin protein is very essential meal for this neutrophil to perform its function of chemotaxis. When this gene is mutated, neutrophil is unable to have its sufficient meal in order to have a stronger legs to move, in order to have stronger, muscles to move to the field where it is needed. So what happens due to that when there is mutation and when there is difficulty? So how this pathogenesis, we talked about pathogenesis, but just we are repeating. So what happened? Mutation of the CTS gene caused what? Deficiency of cathepsin C. This cathepsin C was very important for neutrophil. Okay. When it is not going to neutrophil, when this is deficient, that is not provided sufficient amount to the neutrophil, there is reduced activity of the neutrophil's protein that is called as serine protein. And this serine protein, when not present to the neutrophil, it decreases antimicrobial function of the neutrophil, the chemotaxis of the neutrophil is reduced, and there is inability of the neutrophil to control the pathogen that is present into the body. So it cannot fight with the disease-causing organism, or it is unable to clear all the defective or diseased things or antigens from the body, leading to attachment loss and bone loss. So basically the most important culprit of this condition is bacteria. And the bacteria which is the culprit is Agaricotobacter actinomyceticomicans. This is actually associated with loss, rapid attachment loss, bone loss, and eventually tooth loss. This bacteria is very clever enough. It increases its number. When its number is increased, what happens? The body's good cells are decreased. Good cells mean neutrophil. Neutrophil is not going to the field. Neutrophil is my army. When my army is not going to fight into the field, having its guns not loaded, so what will happen? These bacteria, these nasty bacteria, they will rise. Once they will rise, my body is unable to fire or to shoot them because my neutrophil is defective. So what happens? There is a dysbiosis in the body. Dysbiosis means there is no balance between good and bad bacteria, or the bad bacteria are more in number and the good ones, or my body's good cells, are less in number to find. Because for harmony, we need symbiosis. And we do not have any more symbiosis. That symbiosis is converted to dysbiosis because of this dirty bacteria that is called Actinobacter actinomyceticomicans. And that is usually present in the biofilm as well. And through the biofilm, it penetrates deeper because we said such conditions need a patient to have some periodontal inflammation. So from that biofilm means plaque. So from that biofilm, it entered as deeper tissue. And already my body has defective neutrophil to clear this off. And if this bacteria get chance to multiply, to cause more damage to the body, because it's very clever and it has seen that my body is unable to perform its normal function because one of the main army officer or one of the main troop of my body, that is neutrophil, that is defective. So this way it multiply more and cause problems. So how do you know that patient is suffering from this problem of Papillon-Lefever syndrome? That is actually the disease usually you will recognize with the skin lesions. Okay, this is actually this mutation of gene. We said the cathepsin C gene that not only alter the periodontal attachments, or it not only causes bacteria to attack the periodontal ligaments and all, but it causes some skin lesions or skin problems as well. And these skin problems are called as keratosis. There is a hyperkeratosis. If you see here, there is more of keratin present into the skin that lead to rough, scaly skin, thickening of the skin. So this is actually, it occurs over the skin as palmoplantar keratosis, and usually it develops into the patients of 1 to 4 years of age. It usually involves palms and sole of the feet. That's why we are calling it palmoplantar. Okay, so palms and sole of the feet are mostly involved, but it does act on the other parts of the body as well. So it may extend to the hand and feet. It can go to the elbows. It can go to the knees. It can involve the ankles, and it may spread like this. But usually it affects the palms and the sole of the feet and the palms. So this condition usually worsen when there is a cold weather, because in cold weather there is a dryness, and due to dryness the severity increases, and hyperhidrosis and recurrent skin infection occur in such patient. Though we do not have to do anything with that as a dentist, but we should know that what happens when there are dermatological issues, because we will identify the patient not only based upon his lost teeth or mobile teeth, but we have to, because there are several conditions in which we have lost teeth, we have mobile teeth, that we have to distinguish two conditions, or we have to distinguish such patient from the other conditions. So your main key feature is that the Papillon Lefever is not involving the dentition, but it does involve the skin. So this is actually the way to diagnose the patient. So coming to the oral features, the patient has usually problem with both of his dentition, the primary as well as permanent dentition. There is usually early exfoliation of his primary teeth, the child who is suffering with this. That leads to early exfoliation of the teeth. There is presence of deep periodontal pockets, if you will probe these areas. And there will be, edematous and bleedy gingiva. If you can see here, these are edematous, bulbous, appearance of the gingiva. And if you put the probe in, you will feel increased probing depth. The probing depth is increased because there is attachment loss. Weak attachments are present, and sometimes the patient will complain of separation, halitosis. If you will see the tooth mobility, you will feel that there is marked mobility of the teeth. There is rapid, if you, in X-ray you see, you will find rapid bone loss, and due to that, the child suffers from early exfoliation of teeth. And usually primary teeth are appearing, into the oral cavity normally, but the loss is more. Okay, means before time, but they exfoliate before time. So it affects the age of 4 to 5 years. Now, it does affect the permanent dentition, as we have seen that the primary dentition is lost. Definitely now turn comes for the permanent teeth to erupt. So as soon as the permanent teeth erupt, after some time, there is a start of the inflammation. Again, similarly, the inflammation, then there is a periodontal breakdown, the tissue breakdown, the periodontal alveolar, the loss of alveolar bone, eventually the mobility of the teeth, and the result is exfoliation of teeth. And in early childhood and in very young age, the patient becomes partially edentulous or sometimes completely edentulous. But third molars are least affected because they erupt later in life. This is affecting young age. When the third molar erupts, the child is having the child is sufficiently grown. So it is normally affecting a very young age from, we said it starts from 4 to 5 years of age, and it takes some few years more to cause breakdown. That's why it is not causing third molar involvement. What do you find in the radiograph? There is generalized bone loss. If you will see both the radiographs, you can see there is a generalized bone loss in both the radiograph, and there are angular defects, there are horizontal defects, means there is a horizontal bone loss, there is an angular bone loss, and eventually these losses, severe bone loss, lead to exfoliation of the teeth. Like you will feel that the teeth are floating in the air. If you can see here in this picture in OPG, that teeth are somehow giving feel that they're floating in the air. And there, the bone loss is so extreme that you can see the full length of the teeth. If you can see again in this OPG, there is sufficient loss of the bone that tooth is not supported with any of the periodontal structure. So we said that clinically we diagnose the patient with problems of the skin, and then if you examine the oral cavity, you will find inflammation of the gingiva, increased probing depth, suppuration present. Sometimes patient complain of halitosis, mobile teeth, early exfoliation of the primary as well as permanent teeth. So how do you diagnose this case? As we know that we said this act or this affect the younger individuals. So how do you diagnose this? You will see that child, young age individual will come to you. So one of the diagnostic factor is early onset severe periodontitis. Then second diagnostic tool is you will see that patient has keratosis of palm and soles. Third, you will find that the patient has history of early loss of primary and permanent teeth. There may be positive family history because this is a genetic disorder. And you need to confirm this mutation. When you know all these features are there, then finally you need to confirm this genetic mutation that is of CTSC gene that was leading to actually deficiency or altered production of cathepsin C gene. So these are the diagnostic tools. Once you diagnose the patient, now what investigations you will further need to go in a detail. So investigation are, as we wanted to go for thorough clinical examination, we want to go for full mouth probing charting, we need to obtain intraoral, extraoral radiographs, we need to have a blood count of the patient, a proper blood count, a thorough, complete picture of the blood, neutrophil function assessment, microbiological testing in order to prescribe antibiotics accordingly, genetic testing of the CTSC gene, dermatological assessment. We are not supposed to do this genetic and dermatological or microbial assessment. We will rather be referring the patients for all that, and family screening and genetic counseling. Because if we said the problem is genetic, so after obtaining history, we would be able to send patient to the genetist, and genetist will be making the pedigree, and in order to see how maybe family is not knowing that they are having this problem running into their family, but the genetist would make pedigree, and he would be able to see that how the problem is running in the family. They make actually some tree, so that is called as pedigree. So these are the different ways that we want to be assured of our final diagnosis. So what are the other conditions that are alike? What that are somehow matching this condition based upon the tooth loss and all. So there are conditions that are actually we can be we would we can differentiate from. These are Heim-Monk, because in Heim-Monk again, this is again a disorder in which there is mutation of CTSC gene. So this is actually its differential diagnosis, okay? But few things are different because it has few other abnormalities present, which won't be present with Papillon-Lefever syndrome. And other differential diagnosis is hypophosphatasia. There is premature loss of teeth, but inflammation is minimal. In our condition of PLS, Papillon-Lefever syndrome, we said there is a gingival inflammation. But if it would be hypophosphatasia, then there will not be gingival inflammation. If it is leukocyte adhesion deficiency, it means our white blood cells, the army of our body is defective. And but that defective army inability to reach to the site is due to adhesion deficiency. Okay, they are there, but they do not adhere to the wound. They do not adhere to the site where they are needed. So this again makes the differential diagnosis. Cyclic neutropenia, Chereck-Higashi syndrome, that leads to albinism. So some of the features of Papillon-Lefever syndrome are present in this, but in Papillon-Lefever syndrome, there is no albinism. So we can differentiate patient. Prepubertal periodontitis or other hereditary diseases. So these are actually DDs of the problem which we are right now studying. We are talking about Papillon-Lefever syndrome, but these conditions do match this Papillon-Lefever's clinical, radiographic, as well as oral features somehow. So we need to have knowledge to differentiate. So once we have diagnosed our patient, that patient is having PLS, Papillon-Lefever syndrome, importantly, we need to prescribe antibiotic beside mechanical debridement. You cannot straight away give antibiotic to the patient before debridement. First, you need to perform scaling, root planning, whatever is needed. You need to decrease the bacterial load. Then afterwards, you can prescribe antibiotic as an adjunct, as a support, but not antibiotic as a sole treatment. Okay? But after that, you have to again see, as we said, that we need to have a culture or sensitivity of the patient in order to see which antibiotic is effective to the patient. So what are those common antibiotics which we prescribe to the patient? Amoxicillin with metronidazole, amoxicillin with clavulanic acid, which is called as augmentin, or alternative to these antibiotic where whatever the culture indicate. If maybe culture indicate that patient is resistant to these antibiotics, so we can switch the strategy because our motive is to act on Actinobacter actinomyceticomycans, which is actually causing the periodontal destruction. Okay, so antibiotics, as I said, they are never a sole treatment. Always do mechanical debridement, and after mechanical debridement, we can prescribe patient antibiotics. So moving next, we can send the patient to the dermatologist because this condition is not only having problems with oral cavity, but patient has a lot of problems of the skin. So dermatologist will prescribe some ointments to the patient or systemic medication to the patient that include systemic retinoids or some emulsion or some sort of creams for the topical application in order to, treat these scaly skin or keratotic lesions, because these keratotic skin lesions are prone to have secondary infections. So to prevent that infection to occur, this dermatologist prescribe this treatment to the patient to, provide prevention and care to this patient and provide good healing to the patient. So as a dentist, what we do is we need to provide rehab to the patient. As the child is growing young and missing of a lot of teeth, the child is disturbed with eating, the child is disturbed with phonation, the child is disturbed with mastication. So we need to provide rehab to the patient till patient completes its growth. So first we need to prescribe patient with partial denture, removable partial denture, because we know that if today this tooth is not missing, but you do not know after a few days it would be missing. So we cannot give any sort of treatment like with bridges and all. So we need to give removable partial denture to the patient, that just to improve function and the speech problems of the patient. But when patient is growing age, we just need to be focused on removable partial denture. But now when we know that patient has completed its growth, then you can go for proper planning, like to provide implant supported prosthesis to the patient. But before everything, we have to ask the patient, because child is young, We need to ask the parent to maintain oral hygiene of the patient, and they should have a proper observation on the child, oral hygiene maintenance. They should, bring the child on and off to the dentist for recall visits to have thorough evaluation of his oral habits or periodontal breakdown and the problems of the oral cavity. So if there is good maintenance of the oral cavity and good compliance of the patient, the results are satisfactory. We can prevent the patient from future loss. We can stop the loss, but we can delay the loss. We can somehow prevent the patient from that loss. So that is actually the rehab. And the prognosis, as I told you, normally the prognosis is poor without early diagnosis. If you did not diagnose the patient, if you did not strictly ask the patient to maintain hygiene, to be strictly compliant to whatever you are asking for, then the diagnosis is poor. And prognosis is poor. Early elimination of periodontal infection, close monitoring during permanent teeth eruption, during deciduous teeth eruption, and it's very essential. And we need to provide supportive care to the patient in order to preserve the remaining teeth, if deciduous, if permanent. But if we have diagnosed the patient early, and if we have intervened early, and patient itself is also compliant and maintaining oral hygiene, then we can improve the oral health of the patient, and we can improve the life of the teeth. Maybe the tooth is going to exfoliate after 6 months when the patient is not diagnosed and patient is not getting treatment. But if you have diagnosed the patient early and if you have provided treatment, it may take a few years to the patient. And when after few years, the tooth is going to exfoliate, but at least these 3 years or 4 years or 5 years were good to the patient. Patient was able to eat, patient was able to talk, patient had no difficulty of speech and all. So early diagnosis is very essential. So if you have any question, you please send me a message. I'll reply you, inshallah. And I have taken this all material from this reference book, that is Carenza. Thank you so very much, and remember me in your prayers, and I hope this will be helpful to you.